Hey there again, everyone. This is Adam, and today we're going to be covering a little bit of a basic overview of pediatric and geriatric pharmacology. So, as I'm sure you guys are aware, geriatrics and elderly patients are going to be a huge part of your patient population that you're going to be dealing with when you get out there in the clinical world. We know our population is aging, it's getting older every day, especially as our baby boomers are starting to get up there. In years. And so it's really important to be aware of some of the differences in the way that medications should be used and how they interact with patients as they become older and as organ function starts to decline as the years go on. So just for our definitions here, we'll be using any patients greater than 65 years of age as being geriatric, just to kind of give you an idea of the preponderance of these geriatric patients. You can see here that in 2015 our U.S. population was roughly 324 million people, and of that group, about 15% or so was greater than 65 years of age. So huge number of your patients are going to be fitting into this category, and this number is only going to be getting bigger as we go on. And looking at our U.S. life expectancy, it's averaging around 79 years of age. So again, you'll be dealing with a significant number of patients who are certainly will exceed this number, but you might expect to see patients up to this age with some regularity. So anytime we're going to be prescribing a new medication for an elderly patient, or say we're assessing a current medication regimen, it's really important that we do a really good comprehensive assessment for that patient. So that way we can make sure that we're kind of taking into account all aspects of the patient's situation to make sure we're using these medications safely and efficaciously. And so one of the big assessments that we'll focus on here is going to be this comprehensive geriatric assessment. That's going to be focusing on these patients because as they get older, you'll begin to see that they start to have more and complex problems that will start to kind of rear their ugly heads. And so by looking at kind of a standardized assessment, you can look at different things like their functional ability to, say, take their medications or to even remember they have medications to take. Look at the psychosocial situation they happen to be in. Kind of looking at everything to make sure that we're treating these patients appropriately. So moving on, we'll kind of key in on some of the aspects of this assessment, how that can affect medication therapy specifically. Certainly something you'll be looking at in these assessments is going to be the ability for the patient to perform activities of daily living. So whether it be really just the basic ones like getting up and bathing and getting themselves dressed, being able to eat appropriately. We'll also be looking at things like their intermediate activities. So, can they take their medications appropriately? Can they go out, go shopping for groceries and things like that? Not only are we assessing for the ability for, say, the patient to actually take their medication, but you also want to look to see what type of effects the medications are having on these activities. So, say for instance, if your patient is on a medication that's going to make them experience orthostatic hypotension and they are at a fall risk, that may impede them from really being able to get up in the middle of the night to go to the bathroom because they're going to be a fall risk, and that could lead to even further deterioration in their just their health status in general. So it's important to make sure we're assessing to make sure see kind of what the patient's baseline functionality is at, and to look for changes over time. And because in some cases that could be medication related, or it could be the inability to do some of these activities may be improved by adding on certain medications. So it can kind of go both ways. And so it's important to take that assessment and look for changes over time. Nutrition stats is also going to be really, really important. Not only is it going to be important that the patients, intaking adequate nutrition and they're keeping on their weight and things like that, because obviously that can just affect their entire health spectrum. But certainly to see how medications can play a role with this. So if the patient's not eating appropriately or they're not eating the right types of food, this can negatively impact, say, medication absorption, or say, for instance, they're on warfarin, which is an anticoagulant. If their dietary status changes and they're not intaking the right types of foods, or they're not intaking the correct amounts of certain types of food, it can affect the clotting or the anti-clotting ability of that medication. So say, for instance, you have a patient who is on, say, a stable amount of vitamin K, so they're getting their vitamin K from green leafy vegetables like spinach and things like that. And so you've kind of adjusted their warfarin to an adequate level to where they're perfectly anticoagulated. Well, now all of a sudden, if the patient's not able to ingest that same amount of vitamin K as before. So say, for instance, they're limited dentition or they have poorly fitting dentures or something, they're not able to eat appropriately. Now all of a sudden the patient may run the risk of having too much anticoagulation. It could be at a bleed risk. So again, looking at not only what effect the intake of food is having on your medications, but then also what are the medications doing to the ability for that patient to eat appropriately. So say, for instance, they are on chronic pain medications, say they have cancer and they're on, very high dose opioids. One of the common side effects of that's going to be constipation. And so, if they're feeling really bloated and full all the time, that may prevent them from really wanting to eat, and thus they're not really getting the nutrition they need, which can have all sorts of other effects on them, right? So we'll be assessing that, looking at their medical conditions and how that's playing a role, look at how maybe some of the medications are affecting this as well, when we're assessing just for the nutrition section here. Some of the things you'd want to look at here in this nutrition section is to ask them about a pretty detailed recollection of what they were eating and drinking, and the other type of vitamins or supplements they might have been taking in the last 24 hours, including kind of how much they're getting. And again, this is something you're going to be looking at over time, see if there's any big changes that are occurring. So certainly, asking about vitamins and supplements is going to be really important as well, because depending on your patient and their health literacy, they may not even really consider things like supplements to really be a medication per se, or that it could have interactions with some of their other medications. So it's important to assess for that when talking about their nutrition status. Certainly on the checklist of things you're going to be looking at to see, okay, well, is there any kind of illnesses or conditions that are changing, that are affecting the amount of food that the patient is consuming? Are they not eating frequently enough? Are they getting appropriate amounts of vegetables, fruits, milk, things like that? So all of these things are important when assessing your elderly patients. Other things we'll ask as well, so looking at any type of alcohol ingestion. This can be important, especially if they're on other interacting medications, so other things with sedative properties. So they may, say, have increased dizziness or ataxia, and it could be related specifically to some of the sedative medications they're on, but if they're also ingesting alcohol at the same time, that can exacerbate it and potentially make it worse. So it's important to try to get at least a decent idea of how much beer, liquor, or wine they're drinking on a daily basis. Other things we're going to be looking at, are they having any kind of dentition problems that are making it more difficult for them to eat? Do they even have money to buy food in the first place? Looking at other things like, weight loss over time. Are they physically able to cook for themselves, or do they need someone to do that for them? So kind of assessing for all these different factors when going through the checklist here. There's also a laboratory section here for this assessment. This can be really important as well, especially over time. You want to be checking for changes in some of these values. So, say for instance, you pull a complete metabolic panel. That's going to be kind of getting most of the necessary values to make assessments on their drug therapy. So you're going to be looking at things like their kidney function, their liver function, electrolytes, and things like that. And you're going to be looking at changes over time. So say, for instance, you're looking at, say, their creatinine clearance. You want to have an idea what that is at baseline and if that's changing over time. Because, again, that's going to be affecting how we're dosing some of our medications. You can look at things like protein stores. Again, that's going to be important for their nutrition as well. So if they're not eating appropriately, chances are their albumin levels are going to be low, and that can affect protein binding of medications. It can affect some of the free fractions of those drugs and make them more or less potent, depending on what other things are kind of going on for the patient. So certainly these are good things to you can check for when you're doing a CMP. Other things we'll be looking at, things like serum or lipid panels, serum cholesterol and lipid panels, good for patients who are on anti-hyperlipidemic therapy to check for efficacy of therapy, or if changes in therapy need to be made based on kind of suboptimal levels. If they're diabetic, you want to look at their A1C, check for things like anemia when you're looking at your CBC. And other things like, if your patient's having a sudden change in mental status, maybe they have a UTI that's causing that, so checking a UA, urinalysis to make sure there's no infection going on there. So these are all good labs to get to not only assess for the efficacy of medication therapy, but also to look and see if you need to make any changes over time. So polypharmacy is going to be a big thing when dealing with geriatrics. We'll consider this to be the use of 5 or more medications on a regular basis. And as your patients are getting older, as they get more medically complex, you're going to be seeing that you're going to need more and more medications potentially to manage all their different disease states. And so you'll see some cases where medication use is certainly inappropriate. But really, when you're looking at the increases in incidence of chronic diseases, if you look at trying to follow all the evidence-based guidelines, you see that the medications start to stack up pretty quickly. So if you have a patient with hypertension, CHF, and say diabetes, that list can exceed 5 medications very quickly. And so it's no wonder that in a lot of cases, you won't necessarily be able to get away from utilizing so many medications for these patients. But we'll talk about therapies and strategies as we move forward to try to limit that whenever possible. So just to kind of give you a good example of how the medications can kind of stack up pretty quickly. Say for instance you had a patient who has osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and COPD. They can easily be on something like 12 different medications that they're trying to take at 5 different times per day. And I'm a relatively young guy, and I would have a hard time even keeping up with all those medications. And so to expect someone who is elderly, who may have declining mental faculties or may not have a good kind of psychosocial setup in order to help them maintain compliance with this, you can see it's very easy for issues to pop up with this, right? Not only that, but if you look at hospitalizations, it's very frequent that patients will oftentimes come out of the hospital being treated with more medications they were prior to admission. And so a lot of times you may even see that some of the medications that are being prescribed are counteracting or being used to counteract problems from other medications already on board. So unless you can't really go back and drill down to assess a patient's entire medication regimen to look for potential problems like that, you can definitely get into this issue where this kind of cycle where you end up causing a side effect from a medication and treating with a different drug, which causes its own side effect, which you treat with another medication. And again, it can be definitely inappropriate use of a lot of medications if not dealt with appropriately. So certainly as a consequence of having all the different medications on board, you'll see lots of problems start to pop up. So certainly increased number of adverse drug reactions can occur as you add on more medications. Drug interactions are going to be a big thing here as well, whether it be pharmacodynamic or pharmacokinetic in nature. You can see lots of drug interactions pop up as you add on more medications. Falls are a really big thing as well. So, especially when you have patients who may be on CNS depressants, like, say, a benzodiazepine. They're also on antihypertensives, which can lead to orthostatic hypotension. Very easy to see how fall risk can be a big thing, especially if you have patients who are on anticoagulants, and then all of a sudden they have a fall, then they have a hemorrhagic stroke. Things can go from bad to worse pretty quickly in those cases. So certainly one of the big things you want to be assessing for with your elderly patients. And then decreased compliance as well. So as we increase the number of medications you're on, as we increase the dosing frequency, as we things get more complex, there's less and less likely the ability for your patients to really be successful in sticking with that regimen. So again, like we mentioned, if you have 12 different medications you're taking 5 times a day, it can be very difficult for anyone to keep track of that, much less someone who may have declining mental faculties. So lots of factors kind of come down into the decreased compliance category. So certainly, if drugs have complex dosing schedules and there's many medications to take, like we said, it'd be difficult for me to even keep up with 12 medications 5 times a day, much less someone who's, say, in their 80s or 90s to do this, especially if they're doing it by themselves. It can be very difficult. So some of the things we can do to help prevent that would be to try to keep dosing as simple as possible, and try to use as few dosage forms as necessary. So say, for instance, if we can use combination medications, so instead of taking 2 pills, you can just take 1. That may help with compliance. Or if we can utilize things like long-acting medications where they only have to maybe take it once a day instead of, say, 2 or 3 times a day, that just to increase their chance for success. The economics are really important here as well. So looking at whether or not the patients can actually afford the medications is important. So some of your more frugal-minded patients may not buy the medication at all, or they may start to skip doses and think, well, doc says I should take it twice a day. Maybe just taking it 1 time a day will be okay, right? So obviously medication certainly won't be efficacious if they're not taking it. And depending on how kind of far gone they are and kind of what their ability to complete those activities of daily living, they may or may not need some kind of formal amount of support to make sure they're actually taking the medication. So whether it be a family member or a caregiver, to make sure they're actually being taken appropriately. You can also see issues with mental decline where if they don't remember to take the medication, or if they maybe have forgotten they've already taken a dose, they may get a double dose or forgetting to take it altogether. That can be a big reason for poor compliance. Visual impairment can be a big thing here as well. So if you have a medication bottle that has fairly tiny print on it, and the patient has poor eyesight, they may take the wrong medication or not be able to read the instructions to see how often they should be taking it. Other things that can impact compliance would be if they have a decreased ability to swallow the medication. So certainly we need to consider things like liquid medications in order to help for those patients. You'll also see, especially on the more inpatient side, as patients, especially more frequent flyers, they may have really poor venous access, and so they may limit the ability to give IV doses at the right times that they're constantly trying to fight for access. And then finally, is the patient willing to adhere to the treatment? So maybe all fine and good to want to treat someone's hypertension, but if they're at the end of their life and they are only getting side effects from it, no real benefit, they may not want to be adherent to therapy, and that's okay. But it's important to have those conversations and at least make sure that the provider and the patient are on the same page. So again, our end-of-life patients are going to be those that have less than 6 months to live. And when you're dealing with elderly patients, you need to take things like that into consideration and really try to prioritize and tailor the treatment plan so it's appropriate. You're doing right by them by treating their medical conditions as they want it, and that they are also kind of maximizing their quality of life. So in a lot of cases, it's not going to be so much that you want to enhance the quantity of life. That may not be really possible, but certainly enhancing the quality of life is going to be the bigger goal here. So just to kind of put this in kind of a pictorial form, looking here at this chart, you can see here as time goes on, you see disease progress with ultimately the patient dying. You see here kind of early on in the stages, you want to be looking at treatment of disease. We have this kind of life extension. So, certainly early on in certain disease states, you may be able to extend this out for a long period of time. But as a patient gets closer to that end of life, you're going to be looking more at palliative treatment. So again, you may want to go for another round of chemo to try to treat this patient, but if it's not really going to be all that effective, and it's just going to cause lots of side effects for the patient, it may not be appropriate for them, right? And so that's within the patient's rights to deny treatment, but it's important to have the conversation there. So as our patients get older, we know that there's going to be normal age-related changes that can occur. Nearly all organ systems are going to be affected by this, and so it's important to have an idea of how some of these changes are going to be happening over time, and to know how that can be affecting our medications. So looking at the cardiac standpoint, we're going to expect higher systolic arterial pressures, left ventricular impedance, and eventual decline in function over time is going to occur, and then also reduced heart rate. From the renal standpoint, you're going to expect to see less blood flow going to the kidneys and less actual filtration happening. So your GFR is going to go down over time. And then also you're going to have kind of an impaired ability for the kidneys to really maintain as good of an acid-base balance as a younger patient might. So this can lead to some issues, especially if they have a new illness that comes on, and it can really knock them for a loop because they really don't have the same kind of homeostatic reserve in order to maintain good acid-base balance. Just looking at this graph, you have an idea of kind of some of the changes that are going to be occurring over time. So even starting as early as 30 years of age, you start to see gradual declines in things like pulmonary function, cardiac index, GFR is going to go down pretty linearly as well. Some patients obviously are going to be different and will have bigger deficits than others, but again, it's going to happen to all of us. So we'll get more into the details about this and how this is going to be affecting our medication therapies. Another big organ system is going to be taking a toll over time. It's going to be the GI tract, and so everything kind of starts to slow down. We see decreased HCl and pepsin production within the stomach, decreased gastric emptying time, and just in general, going to have poor absorption throughout the entire GI tract. You can also see in the liver, you're going to have decreased blood flow, metabolism, and which can mean decreased elimination of certain medications. As far as absorption goes, you don't really see a ton of changes in just the actual function of absorption of medications, but some of the things you do see are going to be more interactions with food and other medications. So certainly dietary changes can affect this. So say, for instance, medication needs to be absorbed or is absorbed better with fatty foods on board. Well, if the patient has a lower fat diet, that may lead to less absorption of the medication. Um, Increase over-the-counter medications they may be taking, unbeknownst to you as a provider. If they're taking laxatives, that may help to increase GI transit time, may lead to change in absorption. Antacids frequently bind with a number of medications, which can affect absorption. And then you also have impaired gastric emptying. So the gastroparesis can affect absorption of medications. It can slow it down to some degree. So especially with diabetics, you can see that being more of a problem with them than other patient populations. Changes in drug distribution will also occur as patients get older. So typically what you see is that patients will have reduced total lean body mass and then reduced body water. And in addition to that, they're also going to have typically increases in your body fat percentage. So this chart kind of does a good deal, or does a good job of kind of comparing younger adults versus older adults and some of those changes that occur over time. Obviously, this is going to be affecting distribution of medications depending on how lipophilic or hydrophilic they are. So certainly if you have a higher amount of body fat, potentially a high volume distribution drug would have more space to partition out to in the tissues and thus have a higher volume distribution as compared to someone that had lower fat stores. In addition to this chart, you can also see that serum albumin is going to go down. This may be nutritionally related, potentially for some patients. And if you have less serum albumin, if you have a drug that has a high protein binding, that may affect the free fraction of drug, and it may lead to having exaggerated effects from that medication, potentially. You're also going to see kidney weight go down and hepatic blood flow. So again, just in general, organ function declining over time. So as you mentioned, typically you're going to see protein stores go down for these patients. So decreases in serum albumin can be mainly a result of nutritional status. So if they're not taking as much protein in, they may not be able to keep their albumin stores up. And so this is going to be affecting mainly drugs of high protein binding. Weak acids in particular will be affected by albumin. Or changes in albumin, which may lead to increased amount of free fraction of the drug. Which basically means you have more drug that's pharmacologically active because it's available to bind to the receptors rather than just to the serum proteins. So you may see increased effect from some of those medications. On the flip side of that, you may have increases in certain proteins like alpha-1 acylglycoprotein, in which cases you may see decreased activity of the drug because more of it's being bound up by the protein. As far as drug clearance goes, kidney function will reduce over time. And what you end up seeing is that even though you're doing, say, serial lab values and measuring serum creatinine over time, you may not see there be a good relationship between the increase in serum creatinine and the decreases in their creatinine clearance. So typically the reason for that is that older patients are going to have less muscle mass, and so you have less muscle mass, you're not going to be able to produce as much creatinine. So even though the serum creatinine may be relatively low, it may not really reflect the decrease in renal function that has occurred as time has gone on. Not only that, but you have patients who have dramatically less muscle mass that can affect it as well. So say, for instance, if you have someone who had, say, an amputation, say below the knee amputation, they have a lot less muscle mass in order to actually produce creatinine, which can, again, give you a falsely elevated function. But keep in mind that when you have reduced renal function, you're going to see a prolonged half-life of many medications, an increased risk for toxic concentrations leading to lots of adverse effects. This can also be affected by hydration status. So especially if you have patients who, say, are in the nursing home and they're not really being monitored that well, and say they have a new illness come on board, if they don't hydrate appropriately, that's going to be affecting renal blood flow and thus could lead to decreased elimination of some medications. So again, when you're calculating creatinine clearance for these elderly patients, keep in mind that some equations may not be perfect for every patient. So say, for instance, your Cockcroft-Gault equation, which is pretty good for use in most adult patients. It takes into account the age of the patient, their weight, and also serum creatinine. Keep in mind, as we mentioned just a slide ago, that the serum creatinine value may not be as elevated as it should be just due to the decreased amount of muscle mass. So you may get a falsely elevated value for this, in which case you might overestimate their renal function and not adjust their medications appropriately. So you can keep that in mind. Sometimes you have to use other equations, something like the MD-RD equation, which I have down here on the bottom, may be more applicable for some of your older patients. Some people will even say, well, if I have an elderly patient and their serum creatinine is less than 1, I'll just round up to 1 in order to get a better idea of what their actual function is. And so I see a lot of people go by that kind of rule of thumb. For some medications that require a lot of extensive metabolism in the liver, as you have decreased blood flow, you may see decreased extraction of those medications from the bloodstream and thus decreased elimination and increased half-life. Looking at things like first pass metabolism and bioavailability, you can see that in general you have some decreased function of phase 1 reactions, so this would include like your CYP enzymes, and you generally have very few changes in the phase 2 reactions. Again, the biggest factor here is going to be the decreased liver blood flow you can see, leading to decreased metabolism. It's probably one of the bigger changes that happens in elderly patients, which can be exacerbated by certain disease states. So especially like CHF is going to be one of the big ones, or cirrhosis of the liver. It can again affect flow as well. So that was mainly looking at the pharmacokinetic changes of age. There also see some pharmacodynamic changes that can occur as well. Some people say geriatric patients are more sensitive to medications, and that kind of makes a lot of sense. So some of it's related to the kinetics, in which case they're not able to eliminate medications as appropriately as before. Thus, they may have higher levels than you would expect for someone with good organ function. And then also they just have lessened homeostatic responses, which can change the pattern or the intensity of their drug response. So say, for instance, you give an antihypertensive to a young healthy patient, they can deal with those changes in blood pressure fairly easily. So especially when they're standing up, orthostatic hypotension is not really such a big thing. But for older patients who don't really have a lot of physiological reserve, that can be a much bigger issue for them. And so increased fall risk and things like that. So certainly looking at things like their temperature regulation, fasting blood glucose, and cardiac output can all affect how well certain medications are going to work, or what kind of more dramatic effects you might see from some of these medications. So now we'll look at specific drug class examples and some of the kind of pitfalls you can run into when treating elderly patients. So we'll see that sedative hypnotics and analgesics are going to be a big area of concern for some of your elderly patients, especially considering the fact that they are pretty ubiquitously used and can lead to lots of changes in mental status and also fall risk and things like that. So, you always have to look at your patients and say, well, they had a change in mental status. Is it, worsening dementia, or is it potentially the medications that they're on that could be affecting this? So, sedative hypnotics would include things like your barbiturates, include benzodiazepines, frequently used for treating anxiety and sometimes sleep. A lot of those medications can have pretty significantly longer half-lives, anywhere between 50 and 150%. Over what their usual half-life would normally be in a younger patient. For some of these drugs, they also have active metabolites, meaning that the parent drug is broken down into another product, which can still have pharmacologic activity. And so in elderly patients who have organ impairment, you can actually end up seeing buildup of these active metabolites, which can, again, prolong the apparent duration of effect of the actual drug. And then the opioid analgesics can be big as well, because especially with patients who are chronic pain patients, you frequently see that over time tolerance develops to the analgesic effects, and so you will have to ramp up the doses as time goes on in order to get the same analgesic activity. But unfortunately, you never really get tolerant to like the respiratory depressant effects. So you can end up having patients be at increased risk for this, especially if they are on multiple CNS depressing medications. So if they're on a benzodiazepine in addition to an opioid analgesic, that can just kind of increase your risk for having adverse drug reactions. Psych meds can also be a big target for elderly patients in them being at higher risk for having adverse drug reactions to them. Lithium being a big agent used for treating bipolar disorder. This is highly dependent on elimination in the kidney. So you have any changes in elimination there, you're going to have buildup of levels of lithium, which can lead to some pretty significant changes in mental status and some other CNS effects. So anytime you're adding on drugs which can affect this as well, so things like non-steroidal anti-inflammatory drugs, diuretics, all these things can increase the accumulation of the drug and lead to issues. Antidepressants nowadays is a lot safer since we have newer medications which lack a lot of the side effects of the older ones, but used to use some pretty significant medications that had a lot of different receptor activity, which led to a lot of side effects. So things like our older tricyclic antidepressants like amitriptyline led to lots of negative effects for elderly patients. But nowadays we have things like your selective serotonin reuptake inhibitors, such as fluoxetine or citalopram, have a lot more specific activity and thus have a lot less side effects seen in elderly patients. Looking at cardiovascular agents, obviously with our antihypertensives, you're going to have a bigger risk for orthostatic hypotension in elderly patients, and not only that, but you also run the risk of developing some electrolyte imbalances with things like diuretics. So they could have decreased magnesium, potassium, all can lead to its own problems. Antiarrhythmics can be problematic as well, especially if the patient already has an electrolyte disturbance to begin with. This can increase risk for arrhythmias, and they just have poor hemodynamic reserve than a younger patient might as well. So if they did have an arrhythmia that popped up, they're going to be more prone to having pretty deleterious effects from it versus a younger patient. And for certain agents, you can also see pretty extended half-lives. So some of our older drugs like quinidine or procainamide would fall in that category. So we know that as we add multiple medications on board, we're going to be seeing increased risk for drug interactions and adverse drug reactions that can occur. So even with a single medication, you might have, say, a 10% risk for having an adverse reaction. By the time you add on, something like 10 medications, like it's going to be nearly 100%. There's going to be some sort of interaction or adverse drug reactions happening. It's just a matter of how tolerable it's going to be by the patient. Some things are pretty benign and pretty harmless, whereas you can see some of these adverse drug reactions being very, very significant and having a big effect on quality of life. Not only that, but you also have to look at over-the-counter drug use and also herbal medications, which patients might not always be super good about telling you that they're actually taking them, either due to perceived lack of understanding of the interactions that can occur, or they just may not want to mention it to a healthcare provider who may try to discourage their use. So some errors that we can see are some adverse drug reactions that can happen. So prescriber errors, issues where we are not taking into account age-related changes can lead to some reactions. So if we're not adjusting our doses appropriately based on organ function, or if we're not changing how frequently we're giving medication, can lead to issues there. And keep in mind that you may start a patient on a medication, say age 60, and it's working well for them, but over time, as organ function changes and you don't adjust the dose as you go along, that can lead to problems down the road. So even though their dose has been on for years, now all of a sudden it's a problem because they're not clearing it as well. You can have issues with patient compliance errors. So again, if they are not able to, they don't have the mental faculties to really keep up with the medications, or no one's there to keep them on track, there can be errors there. And then also if you're seeing multiple providers, so they may go see the primary care provider, but they may also see specialists for other issues. And so if they don't all communicate with one another, there's a lack of understanding there that you have multiple providers ordering things. You may have therapeutic duplications that the patient might not even know about, and so you can end up having some adverse drug reactions from that as well. And then also one thing I've noticed as well is that some patients may not even recognize certain drug products as actual medicine. So say for instance, I have lots of older patients who talk about their BC powders or their goodies powders, and they don't even realize that it's aspirin. So I've had several errors where patients were taking quite a bit of this stuff for their headaches, and didn't realize that they were this, in addition to the aspirin they were taking for their headache, all were leading to some very super therapeutic concentrations and leading to some pretty big problems. So it's always really important to do a good structured history of medications that the patient's taking. So here are just some sample questions that I think are important for asking every patient every time, so that way you make sure we're kind of capturing all facets of their medication use to look for potential problems or opportunities for changes. So again, are they taking the drug as prescribed? Are they experiencing any side effects? And there could be certain things over time they've just gotten used to, so they may not recognize it as a side effect necessarily. But it's good, if they're taking specific medications that have pretty well-known side effects, ask about those specifically if they're having any issues with, so say for instance, tinnitus is a common side effect of aspirin, especially with overuse. Ask them if they're having any ear ringing. It may be something they may not necessarily equate to being a problem with the medication. Obviously, asking about over-the-counter drug use, so asking specifically, are there things you're taking that you don't need a prescription for, can help to try to pick out some of those ones that they may not be telling you to take right off the bat. Homeopathic and herbal medications are super important as well, because some of them, even though they may not be seen as medications by the patients, they can certainly have some very significant interactions. So something like St. John's wort taken for depression in addition to an antidepressant can lead to something like serotonin syndrome, which can be very significant for your patient. So important to try to get those medications out on the air as well. Other important things to assess for when asking these questions of your patients, especially, is going to be how they're actually using their medications. So when looking at things like eye drops or inhalational therapies, are they using it appropriately? Because if not, they may not be getting really a whole lot of benefit out of using it. So like inhaler technique is super important to assess for in your patients to make sure they're actually getting the medication to the lungs where it's needed versus just either swallowing it or not inhaling it at all. So again, technique is going to be super important to assess for your patients. Ask them about how they remember to take their medications. Do they have any kind of reminder system, or do they have some people to help with them? And this can make sure that you're getting a little bit better compliance than just having a bunch of pill bottles sit next to each other. This has helped to really keep it more structured for them. So again, there's lots of barriers to making sure your patient's really compliant with their medications. Keep in mind that expense is going to be a big thing for many patients, especially if they don't have pretty robust insurance to cover a lot of medications. So say for instance, a newer NSAID, non-steroidal anti-inflammatory drug may say be hundreds of dollars per month, whereas aspirin is only $5 a month, or ibuprofen is 10 to 20. So just because a new medication is new and it's kind of the hot new thing to try, keep in mind that it's probably going to be more expensive and may not be covered by your patient's insurance. Again, other barriers can be if you're using medications with mixed dosing intervals, so you can try to use things that have similar, say, once daily dosing or twice daily dosing versus getting it all mixed up. And there with some patients that may have this intelligent non-compliance where they may say that they're taking it when in fact they are not. And this could be, apparent by looking at, if they're saying they're taking their antihypertensive but they're not getting into range, this could be a sign of poor compliance. A lot of times it could be related to again, cost of medication. If they can't afford it, they're not going to buy it. Could be related to issues of side effects where it's just not tolerable by them. So, unless they're being candid with you and telling you about this, they may just say, yeah, I'm taking it when really they're not. And then one other factor would be, can the patient physically take the medication? So looking at changes in functional status over time. Do we need to look at using things like liquid medications as an alternative or something to make it so that they can actually take the medication appropriately? All right, moving on. The next thing we'll talk about is going to be pediatric pharmacology. So the question is, what's so different about this population? And really the thing is, it's a pretty heterogeneous group that's undergoing pretty constant physiologic changes, especially during the very early periods. The other thing that makes it a little bit more difficult in regards to medications is that we don't really have a ton of pharmacokinetic and dynamic data in children, at least not as robust a data as we have with adults. Again, this is a protected group, so it's a little bit more difficult to do the kinds of studies in kind of the numbers that you would want to see with like an adult to get that kind of definitive data. So in some cases, you're having information being kind of extrapolated back from adults and having it applied to pediatric patients, and which may not always be completely accurate. But oftentimes it's kind of what we have to do. So just the first little bit, this will be kind of like a case and question based kind of section. But the first thing we'll talk about is a little bit about kind of the nomenclature for dealing with pediatrics. So the first little case snippet we have here is Braden. He's an 8-day-old male who's admitted to the PICU for pneumonia. He's a former 34-week gestational age baby. So question will be, which of the following statements is or are correct? Braden's postnatal age is 7 days. Braden is a preterm neonate. Braden would be referred to as an infant. A and B or E, none of the above statements are correct. So in the upcoming slides, we'll kind of talk about the information and then come back to this question. So as far as the lingo goes that we'll use when we're talking about pediatrics and when we are looking at drug references and getting the information that we need to, dose medications for children. First thing we'll talk about is the gestational age, and this is going to be the maturity at birth. So it's going to be based on the date of the last menstrual period and that on physical exam as well. The postnatal age will be the chronological age after they are born. And then the post-conceptional age would just be the postnatal plus the gestational age. I'll tell you that gestational age and postnatal age are probably the most frequently used. Don't oftentimes see post-conceptional being used in regards to medication dosing. Gestational age is really, really important when we are talking about neonates specifically, and we'll talk about why that is in regards to their maturity of their organ systems. As far as their gestational age goes, when they're preterm, that would be less than 37 weeks gestational age. They would be full term if they're 37 to 42. Post-term would be greater than 43 weeks of age. And then we will say that the newborn or neonatal period is going to be 0 to 1 month of age. And then the infant period would be that first month through 12 months of age. You'll oftentimes hear people refer to newborns as being infants as well, but just know that there's a little distinction there, that newborn neonate would be that first month. Toddlers will be anywhere from 1 to 2 years of age, young child 2 to 5, older children 6 to 12, and then adolescents would be 13 to 17. Again, as you start to get older and the patients are getting bigger and more mature, especially in the adolescent stages, a lot of times you'll see the drug dosing will kind of go back to being a little bit more consistent with what the adult practice is. But certainly in the younger ages, we'll be looking at things like their gestational age or their postnatal age in order to come up with specific dosing based on usually organ function. So coming back to our little case snippet, so Braden, as we say, he's an 8-day-old male, admitted to PICU for pneumonia. He's a former 34-week gestational age. So which of the following statements would be correct? Braden's postnatal age is 7 days. We know that to not be the case since it said it was 8 days after being born. Braden would be a preterm neonate. That would be true. And then Braden would be referred to as an infant. Since he is within that first month period, he would actually still be considered a newborn or a neonate, so we would not call him an infant technically. So it would make the answer B. Okay, so moving on, which would be correct concerning absorption in neonates? Acidic medications are better absorbed in the neonatal GI tract. The intramuscular route is preferred because of increased blood flow and contractions, muscular contractions. There are no differences in topical absorption in preterm versus term infants. A and C, or all of the above statements, are incorrect. So we talked about this before in regards to adult patients, but absorption is going to really be coming down to the physicochemical characteristics of the drug and the formulation that it's in. So the molecular weight, particle size, pH, and pKa of the drug, the dosage form that it's in, all that's a factor on how well these medications will be absorbed. And we know that's going to play a role in the different anatomical sites that it could be absorbed from. So obviously the pH of the stomach is going to be a lot different than the pH of the duodenum, etc. And that's all going to have a factor on where the medications will be best absorbed in the GI tract. So the two major determinants that will be seeing affecting gastrointestinal absorption of drugs for these pediatric patients is going to be the gastric acidity and then the gastric emptying time. And so that's going to be very different between infants and adults. Not only that, but you're looking at preterm neonates versus term neonates. You'll see that's also going to be different as well. So looking at pH-dependent passive diffusion, remember we were looking for things to be in their uncharged state, because again, they're going to have an easier time crossing those lipid membranes. And looking at the gastric pH in a full-term infant is around 6 to 8 for 1 to 3 days after birth. And that kind of makes sense if you think about what the GI tract has been exposed to, and it's really just been the amniotic fluid from the mom. So the kid's been kind of swallowing that kind of passively during gestation, and so they really haven't had time to wash out that amniotic fluid and then to ramp up their own hydrochloric acid production. So you'll see that pH will be even higher in preterm infants. They'll even have a different, kind of a higher pH, which may or may not be suitable for absorption of certain medications. And we will see that the greater their gestational age, the better gastric acid production they'll have. So the preterm infants are going to have a little bit longer time before they'll actually get to kind of full acid production. And so as we said previously, we said that for acidic drugs, because the pH is going to be higher, we are going to be in a medium now where we have an increased amount of ionization, which means we'll have actually worse absorption, so decreased absorption of acidic medications. For basic medications, though, we will have decreased ionization, and in there we will have increased absorption. So for basic drugs, you have better absorption. For acidic drugs, you have worse. In regards to GI emptying time, we also see that the transit time is going to be much slower in infants, less than 6 months of age. So it's going to lead to delayed absorption of the medication. It'll probably also happen to the same extent. It just may take a longer period of time for those blood levels to reach their kind of maximum. And then you'll see lots of different things can affect and make this slower or faster. So for instance, congenital heart diseases, if the patient has impaired perfusion, obviously the body's going to be trying to maintain blood flow to the heart and the brain and all those important organs. GI tract kind of takes a back seat to that. So those kids who have congenital heart disease may have decreased blood flow to the GI tract, which will just, again, slow down gastric emptying time even further. Moving on from absorption within the GI tract, we'll now talk about the intramuscular space. And we'll see that intramuscular absorption of these medications is dependent on several factors, one of which is going to be blood perfusion to the area of injection. So the better the blood flow to the area, the better absorption is going to be. And then also, once the actual drug is in the muscle, the rate that the drug can penetrate through the capillaries, which again goes back to its lipid solubility. And then also the apparent volume into which the drug has been distributed. So when we're looking at neonates and infants, they're going to be differing from older children and adults because one, they have less blood flow going to the muscles. And in general, they have a higher percent of water within the muscles. They're kind of, someone described, young pediatric patients as kind of being big bags of water. So for those medications, especially that are more hydrophilic, they're having a higher apparent volume of distribution because of that. And so it's going to work to slow down absorption of medication from these intramuscular spaces. They're also going to have a decreased extent of muscular contractions, which means that the drugs are going to penetrate quite so well or as quickly. And then one other factor is going to be that they generally are going to have kind of instability in their peripheral vasomotor ability to really maintain their temperature. So because of that, normally in response to fluctuations in temperature, the blood vessels will contract or dilate in order to help increase blood flow and get rid of heat. Young children can't really do that also well, so that again can lead to kind of erratic blood flow to the muscles and lead to more erratic absorption of the drug. Rectal absorption, the rectal route's a great way to administer medications to children, especially if they have a hard time taking things by mouth, and you don't want to give something via the intravenous route. So we will see that the tissue down there is very vascularized. It's pretty thin for the most part, so we do end up seeing higher bioavailability for some medications due to this increased mucosal translocation. Other factors you do have to weigh against this good rectal absorption is that neonates and children have an increased amplitude of rectal contractions, so you do have the potential for losing some of the medication if it is eliminated prior to being absorbed. Getting IV access in infants can be very, very difficult, given how small and thin their veins are. So one of the routes of administration that we can utilize, which we're seeing quite a bit, especially if you need emergent access to the intravenous space, would be going via the intraosseous route. And so basically, you can either do this manually with kind of a screwing type technique, or most places will now have kind of a screwdriver, kind of a mechanical gun that will embed this needle down into the bone and getting into the intraosseous space. Again, that is basically, it's a very easy way to get access, and basically it's like a non-compressible vein, so you get very good blood flow through that area. It's a great way to administer medications or fluids when you need to. So, like I said, you'll see it more often in emergent situations or in cases where IV access cannot be otherwise obtained. As far as percutaneous absorption of medications go, you see that children generally are going to have an underdeveloped stratum corneum. And as we saw previously when we were talking about things like Fick's law, is that thickness of the stratum corneum is going to be inversely related to the absorption. So the thicker the skin, the harder time you have absorbing drugs, versus the thinner the skin, or the more underdeveloped it is, the easier time you're going to have to absorb medications. With kids, you're also going to have, you're going to see the skin is going to be very well hydrated and very well perfused. And so the more hydrated the skin is, the easier time we're going to have drugs to be absorbed through that and get absorbed. And then not only that, but you will see that pediatric patients, their body surface area, the ratio of their BSA to body mass is significantly increased compared to adults. So covering a given amount of skin for them is going to be much higher proportionally than you would see with an adult. And so can result in toxicity if the medication is applied topically and you're not really taking that into account. So you've got to be very careful with that and which medications can be given transdermally. So as a good example of this, when I was doing my fellowship at the Poison Center, we did have a case where a patient was inadvertently, I think they were 2 months old, and mom was trying to apply some diaper rash cream and didn't realize that it was dad's special compounded cream that he had for chronic back pain. And so the cream had all kinds of products in it, so things like amitriptyline, ketamine, all kinds of different medications in it that can be pretty detrimental to a kid, was applied to with a diaper laid. Obviously, if they're given for diaper rash, kids probably already has very erythematous, well-perfused skin, and that just led to very good absorption. Now, most of those drugs would not be absorbed through the skin of an adult because we have a nice developed stratum corneum. But for this kid, he was able to absorb quite a bit of it, and before they knew it, mom found the kid unresponsive. So they had to intubate the child, bring him into the PICU, and eventually allow the drug to kind of clear itself and be eliminated. And so we did blood levels of things like ketamine and amitriptyline did get positive levels in the bloodstream. So you got to be careful when applying certain medications topically to kids because they do have a pretty good absorption for the most part. So going back to our question, which of the following statements is correct concerning absorption in neonates? Acidic medications are better absorbed in the neonatal GI tract. We know that to not be the case because we know the pH is generally higher than in a fully developed GI tract, so that would not be the case. It would be false. The IM route is preferred because of increased blood flow and contractions. Again, that would be false because typically they have kind of more erratic blood flow unless you're going to have more erratic absorption. And then no differences in topical absorption in preterm versus term infants. That would also be incorrect. So again, all of the above statements would be incorrect in this case. All right, so our next case will be baby girl James. She's a 2-day-old female. She's admitted to the NICU for respiratory complications and is a former 32-week gestational age baby. So which of the following would be correct? She would have an increased volume distribution for lipophilic medications. Volume distribution would not be affected by edema. She's having secondary to her respiratory complications. You should consider dose adjustments for increased protein-bound medications. A and C or none of the above statements are correct. So as we discussed before, we know vomit distribution is more of kind of a mathematical concept, but it's relating to how much amount of drug is in the body to the serum concentration. And again, we said that vomit distribution equals our dose over C0, which is our initial concentration. And so we'll see how this is going to differ between pediatric patients to adult patients. So generally what we'll see affecting vomit distribution is going to be the lipid solubility of medications. So the higher lipid solubility, the higher the vomit distribution will be. Plasma protein binding tends to have the opposite effect, where the higher amount of drug that is being bound by plasma proteins is going to keep more of it in the central circulation, so it's going to be decreasing vomit distribution. Higher tissue binding will make it have a higher vomit distribution, because more of it will be bound up out in the periphery. And then just how kind of extensive the peripheral tissue distribution is going to be, so that would increase vomit distribution. And then we'll also see certain disease states will affect vomit distribution as well. So especially critically ill states like burn victims, they have significant edema. Those would all be things to increase the vomit distribution for certain water soluble drugs, just due to the higher water volume within the body. When looking at our newborn infants, we'll see that they have a higher water percentage than adults would. So roughly 70 to 75% of their body weight is just water, and they tend to have a higher extracellular water component than adults would. So say 40% in infants versus just 20% for the adults. That, in combination with the fact they have less fat tissue and less muscle tissue for their given weight, means that for hydrophilic medications, they're going to have a higher volume distribution. So since they have so much water out in the periphery, if we were to administer a dose intravenously and then measure that blood concentration, the blood concentration would be lower because more of that drug is now partitioned out into the tissues due to that increased water content. So the opposite would be true for lipophilic medications as well, to where they would have a relatively decreased volume distribution based on the fact they have less fat tissue. So essentially, when looking at pediatric patients, they're basically just big buckets of water. So because of that, they in general will need a higher dose on a mg per kilogram basis to get the same given concentration as you would for an adult, because so much more of it is far distributed out into the tissues. So say for instance, to get a given concentration of a drug, say 10 milligrams per ml, you may need to give, say, 100 milligrams of the drug to a pediatric patient versus only, say, 50 to an adult, because of the higher volume distribution. So as an example, we have a drug here, gentamicin, which is an antibiotic used pretty frequently for neonates and infants. And we'll see that based on their patient age, you'll see that their volume distribution is going to be decreasing as they get older, because again, you're going to get more muscle, more fat tissue, and so the total amount of body water is going to go down on a percentage basis. So say for neonates, gentamicin volume distribution may be anywhere between 0.5 to 0.6 liters per kilogram, versus for an adult may only be 0.2 to 0.3. And so that comes into play when you're looking at the dosing of it. You look at the dose for neonates can be 4 to 5 mg per kilo versus 1 to 2 mg per kilo for an adult. So even though we're giving pretty vastly different doses here, you would see that you should still achieve the same blood concentration. It's just that the volume distribution is higher for the pediatric patients than you would see for the adults. And again, when you're looking at your drug references to get dosing for a patient, this dose has already been taken into account with all these different pharmacokinetic changes, and so that's where that number really comes from, is based on these changes. Other things we'll see in young children is that they will, in general, have decreased plasma proteins. So decreased plasma proteins, decreased protein binding, and decreased protein stores early on in life. And again, if they are, the more immature they are, the less proteins they're going to have. And so not only that, but you can also have some binding interactions where you can see that certain endogenous compounds will actually compete for that protein binding. So bilirubin is typically higher in neonates than you would see in older patients. And so because of that, anything that would displace the bilirubin off of the proteins in the blood can lead to jaundice. And so that's where certain drug interactions will come from, is by this drug binding to the plasma proteins. So another good example of this would be a drug used as an anti-epileptic. That's called phenytoin. And so this one has roughly 90% protein binding. And so that 10% that's free is what the actually physiologically active component is. That's what's causing the anti-seizure activity. So if I were to give a dose of phenytoin to say a preterm neonate, because they have decreased plasma proteins, I'm going to end up having a higher free fraction of that phenytoin than I would normally. So what you may end up seeing is kind of more exaggerated effects because their free fraction is higher. So say, for instance, instead of having 90% protein binding, which you would see in an adult, you may only have, say, 70 to 80% protein binding. That means you've effectively doubled or tripled your free concentration, and thus you're going to have more kind of dramatic effects than you would expect to see just based on the blood level. So going back to our question, which of the following are going to be correct? They would have an increased volume distribution for lipophilic medications. That would be false. It would be increased volume distribution for hydrophilic medications. VD would not be affected by edema. That again would be false because again, in those critically ill states, you're increasing total body water. That would definitely affect the volume distribution for hydrophilic medications. You should consider dose adjustments for increased protein-bound medications. Absolutely, because again, they are going to have decreased amount of plasma proteins, and that's that can lead to alterations in that free fraction of drug. So A and C, no, and then none of the above statements are correct. That would be false as well. Okay, so our next question is going to be regarding metabolism in neonates and infants. Neonates would have a decreased quality and quantity of enzymes. Medications metabolized by CYP P450 enzymes and sulfation would have an increased half-life. Neonates need increased morphine doses secondary to increased glucuronide activity. A and B, or all of the above statements, are correct. So we know lots of factors are going to play a role in metabolism of medications, and we see that especially in the early stages of life, the metabolism pathways are pretty immature for the most part. So we'll see that increased gestational age and postnatal age are all going to lead to more fully developed metabolism. We'll also see as time goes on, we'll have changes in hepatic blood flow. We'll have an increase in the size of the liver. We'll also have an increase in the quantity and the quality of the actual hepatic enzymes being developed. And then we can see other factors that will affect this include certain disease states, so especially like liver failure, or if we have certain congenital conditions that impair liver blood flow. And then you could have potential interactions where you have some enzyme in either induction or inhibition leading to alterations in metabolism. So looking at the phase 1 reactions that occur, again, this is where our CYP enzymes come into this. And remember, the net effect here is we're trying to make the drug molecule either more soluble, or we're trying to uncover kind of a functional group where we can add on a moiety in the phase 2 reaction. So here, though, oftentimes we're adding either sulfur, hydroxyl, carboxyl group, again, to increase that water soluble. Increase the water solubility. Here it can either go to the phase 2 reactions, or they can be excreted directly either in the bile, the lungs, or the kidneys. Again, here we'll see that the major examples will be either oxidation, reduction, hydrolysis, and demethylation. Oxidation probably being the big one that we see with CYP enzymes. So with our phase 1 reactions, the CYP P450 pathway is in general about half the full activity as you see in the adult with a full-term infant. As you might imagine, with a more immature or preterm infant, you're going to see they'll have even less activity. So over time, though, the number and the quantity and the quality of the enzymes will start to ramp up to where in some cases you may actually have increased activity over what you would see with an adult. So a good example of that would be oxidation of phenytoin, which at 1 year of age, kids are actually metabolizing it 2 to 5 times faster than you see an adult metabolize it. So for those patients, you may need to give a higher dose on a milligram per kilogram basis in order to achieve sufficient blood levels for its anti-epileptic activity. And so you'll see that in dosing guidelines will say, from this age, you give this many milligrams per kilogram, then you see it gradually go down into adolescence and adulthood. As far as phase 2 reactions go, we'll see that again, we're going to be adding on a group to these molecules to make them more water soluble, and then once they go through this pathway, then they'll be excreted by either the bile or the kidneys. And again, so we're going to have additions of the sulfate group, a methyl group, glucuronide, or a glycine conjugation. As far as specific pathways, you'll see some of them are going to be well developed, some are going to be less well developed depending on the patient. So an example of something that's very well developed at birth would be sulfation, which is important for metabolizing acetaminophen. This is why kids tend to have a pretty high dose tolerance before you start to see hepatotoxicity, because they have such a good sulfation pathway at birth. On the other hand, though, you may have certain pathways which are going to be underdeveloped at birth. It may take some time to really get up to kind of full functioning. So for example, with the metabolism of morphine, the glucuronide conjugation is actually underdeveloped at birth. It doesn't mature until around 3 years of age. So for those kids, they have a decreased amount of the drug being metabolized, which means your dose on a relative scale is going to be lower than you would see, because otherwise they're going to build up of the drug, which can lead to increased CNS and respiratory depression. Another good example of something you want to avoid completely is going to be administration of benzyl alcohol. It's not a drug itself, but is a preservative found in many products. And so since kids are not able to conjugate glycine appropriately at birth, this makes it a very toxic compound because they can't get rid of it, and so you end up having some very significant morbidity associated with the administration of that. So that's why you see for neonates, you're most often giving preservative-free products that does not include that benzyl alcohol. So going back to our question here, which of the following would be correct about metabolism in neonates and infants? Neonates are going to have a decreased quality and quantity of enzymes. Yes, that would be correct. Meds metabolized by CYP and sulfation would have an increased half-life. Not necessarily. Certainly for the CYP enzymes, that would be true, but sulfation pathway, we said at birth, is fully developed. And that neonates would need higher doses of morphine secondary to increased glucuronide activity. So that was actually the opposite. They actually have a decreased glucuronide activity, so they would need relatively a smaller dose or one given less frequently because of that. So here we'd have A would be the only correct answer here. Next, we'll talk about elimination of drugs within the kidneys. So which of the following would be correct about excretion in the neonates? They would have a decreased GFR, tubular secretion, and tubular reabsorption. Creatinine clearance estimations are difficult within the first week of life. Neonates have decreased excretion secondary to decreased pH. A, B, and C, or all the above statements are correct. So as far as excretion goes, we know that most drugs are going to be renally excreted, and so the excretion is going to be dependent on lots of different factors, but some of the big ones we're going to look at include the number, size, and quality of the glomeruli, which are obviously going to be fairly immature at birth, especially if you have a preterm neonate. How extensive the protein binding of the drugs is. So the more higher protein bound it is, the less likely it is to be eliminated through the kidneys. Renal blood flow is going to have a direct relation to how well drugs are eliminated. So less renal blood flow, less drugs getting filtered, and that's eliminated. Other concomitant disease states that can affect this. If you have certain nephrotoxic medications are on board that may be causing some kidney injury and impaired excretion. And then we'll also see that urine pH and the urinary drug concentration is going to be affected as well. So as we said with GFR, in general, you're going to see with neonates that they have an increased serum creatinine for the first week of life. And that kind of makes sense because if you imagine their blood flow, their blood supply is coming straight from the mom, and so if mom has a serum creatinine of, say, 1, then the kid's probably going to come out with something very similar to that. And so even though this isn't really reflective of what their actual renal function is, that's why calculating creatinine clearance in that first week of life isn't really all that useful. But you will see renal function start to increase during that first 1 to 2 weeks of life or so, and it should get relatively normal for a neonate around that time period. But again, the more preterm the baby is, the more immature and decreased quantity of glomeruli they'll have. They'll also have some immature proximal tubules and potentially some reduced renal blood flow as well. So just to give an example of what GFR looks like for the first few months to years of life, you start to see that, neonate during that first month of life may only have a GFR of roughly 30 to 40. But then as you go, as they start to get older, you'll start to see that number of glomeruli increase, and that's you'll have better flow. So, by say 6 months of age, they're relatively at a normal level compared to an adult. So because of that, because of the renal elimination changes for certain medications, you have to change your dosing as well, because things like the half-life is going to be different based on how well the kidneys are going to be filtering that out and eliminating the drug. So say, for instance, we go back to gentamicin, it's a drug that already had some volume distribution changes based on its hydrophilicity and how water soluble it is. We also see changes in half-life based on the renal function as well. So, during the first week of life, the half-life may be anywhere between 3 to 11.5 hours, depending on how immature the baby was when it was born. And we'll start to see that the half-life will get shorter as you get older and as the renal function starts to mature more. And so because of that, things like gentamicin may need to be administered less frequently, especially in preterm infants, to where you may be giving it, say, every 24 hours for a term infant versus every 48 for one that was born, say, at 24 weeks gestation. Looking at secretion and reabsorption within the kidneys, we'll see that both are going to be significantly decreased within the first year of life. And some other things that are going to come into factors with that include decreased renal blood flow, which can lead to impaired secretion and reabsorption, decreased ability to concentrate urine within the kidney, and then in general you're going to have lower urinary pH values as compared to when they get older. So going back, which of the following statements would be correct about excretion in neonates? Decreased GFR, tubular secretion, and tubular reabsorption. That would be correct. Creatinine clearance estimations are difficult within the first week of life. That absolutely is true as well. One of the things you'll tend to look at more so than just looking at their serum creatinine, since we know that's not accurate, especially during that first week, is you'll actually be measuring urine output instead. And so in general, what you want to look for is 1 ml per kilo per hour. Should be how much urine they're outputting. And again, that's a good sign that they are having good renal flow, and they're filtering out an appropriate amount. So changes in urine output are really good to trend over time to look to see if they're having any significant changes in renal function. Neonates are going to have decreased excretion secondary to decreased pH. That one is also going to be true here as well, because again, due to the fact that more medications are going to be on the weak acid side, because you have a lower pH, they tend to be more in that unionized state, and thus they have an easier time being reabsorbed through the renal tubule. So you would have end up getting more of it recirculated into the body in less excretion. So in this case, all of the above statements would be correct. So now we've figured out kind of all the differences in metabolism, excretion. The next question is, how do you actually dose medications for pediatric patients? So there's several different strategies. One of the ways we can do this first would be age-based dosing regimens. So for instance, we have a drug like codeine, which is a analgesic, gets metabolized over to morphine where it has this activity. Here you see that at different age ranges you have different flat doses that you would give. So say for instance you have a 4-year-old, you look at the dosing range here and you say, okay, well I'm going to give them say 5 milligrams every 4 hours as needed for pain. Right? As they get older, obviously they're going to need a bigger dose. The advantage of this is it's pretty easy to use in practice. You just know their age, you look at the dose, and you pick one out and go. The disadvantages, though, is that this assumes that you're going to have equal maturation of the pharmacokinetic principles of absorption, distribution, metabolism, and excretion are going to be the same in all the patients, right? So looking at, if you had a 2-year-old, one that was born at 24 weeks is going to be different than one that was born at full term. So because of that, those assumptions might not always hold out. And not only that, but you're not doing it based on weight. So, pediatric obesity is something that's becoming more and more prevalent. And so this may not take that into account. And so you may end up either overdosing or underdosing patients if they're at either extremes of weight. Probably the more common way to dose medication in children is going to be body weight based dosing regimens. Here I have an example where neonates or infants would be getting, say, 20 to 30 milligrams per kilogram a day divided every 12 hours versus infants greater than 3 months of age. You'd have a higher dose based on, and this takes into account changes in metabolism and excretion and the like. And then typically you'll have an adult dose, which is kind of your max. And so keep in mind, though, that as you get with older kids or heavier kids, you don't want to exceed the adult dosing. Otherwise, you're going to increase your risk for toxicity. Again, this is the most common way that drugs are being dosed, and it helps to avoid having dosing errors when you have kids that kind of fall outside the normal weight ranges. Some of the disadvantages of using body weight dosing is you have very extremely overweight children. You do run into the potential for overdosing or underdosing them because of the fact that once you get to a certain weight, you're just putting on fat tissue at that point. You're not necessarily increasing the size of the liver to metabolize it more quickly, or the kidneys and whatnot. So because we're having an increased incidence of overweight children, this is something we have to take into account. So again, capping off your doses at adult doses, and in some cases we'll actually end up using adjusted body weights based on how large they are. So that way the doses are a little bit more similar to what you would see in published references. Another way that you can dose medications for pediatrics would be with body surface area. So for an example, the drug corticotropin, you would dose at 150 milligrams per meter squared, IM divided twice a day. The advantage for this is it's pretty precise for those kind of more high-risk medications. So oftentimes you'll see chemo medications, especially for children, being dosed on body surface area. And it also will help to limit some of the potential for overdose based on the weight of the child. So if they're very, very heavy, but their height really hasn't caught up with that, it's going to take that into account, so you don't have as big of a potential for overdosing. Some of the disadvantages, though, is it's difficult to estimate length or height in children, especially if they're not being very cooperative. So it may lead to some inaccuracies there. And there's also numerous BSA calculations, so it's important that wherever you work that you kind of figure out what their standard is and make sure that you're being consistent with that. Okay, and the next question, which of the following statements are correct about drug administration and dispensing? Providers must obtain a current weight whenever dosing medications. Children may receive a higher milligram per kilogram dose than adults, but a lower volume administered. Adherence to oral medications includes consideration of inactive ingredients. A, B, and C, or none of the above statements are correct. So some of the things to consider when administering medications via the intravenous access for kids. One, you want to look at the site of administration. So you'll see that in a lot of cases, IV access is pretty tenuous in patients, and you always worry about extravasation of medications and whatnot. A lot of times if you have kids who are frequent flyers, like chemo kids and things like that, you end up having to have like central lines placed, implanted ports put in, so that way they always have ready access, because getting a peripheral line can be pretty difficult. And not only that, but for certain medications, you can see that due to their vesicant nature, giving them in a peripheral line can lead to thrombophlebitis, and you can see, if you have an extravasation, you can see lots of issues there with tissue necrosis, etc. So a lot of the times you have to be aware of those medication-specific actions. So a good example of that would be something like phenytoin, as we mentioned, for seizures. It's very difficult to go in solution, and so they have to keep the pH pretty high, somewhere around 11, to keep it in solution. And so if you were to extravasate that, you get that purple glove syndrome that we talked about. And so whenever kids coming in seizing, you need to give them the phenytoin quickly. We always try to make sure we're using the deepest and largest vein you can to help to mitigate some of that risk there. You also have to look at things like the volume of drug that's being administered, because if you're giving it in too dilute of a solution, you can see things like fluid overload, or you could have electrolyte disturbances that can happen secondary to that. So volume of the drug is very important. You also have to look at, are they getting multiple drugs, and look at the corresponding frequency. So look at things like drug compatibility, and because you don't want to be coming in and giving a kid medication 4 a.m. When getting them to sleep was hard enough to begin with. So looking at drug administration and the frequency is important. You can also have issues of mechanical or technical problems. So especially working in a peds hospital, we use a lot of technology to try to make sure that we're administering these drugs appropriately, but there's still problems that can pop up. So certainly if I were to have multiple medications being hung on a patient, it's important to make sure that we're programming our pumps correctly, and we're making sure that things are being done appropriately, otherwise you can run into problems. So say for instance, a patient who's getting total parenteral nutrition or TPN, typically they'll have one bag full of the TPN product, and they'll have another bag full of lipids that are hanging, and they will be at different rates. And so we've had cases where nurses will input the rates incorrectly and juxtapose them, and thus the patient gets one drug too quickly and the other one too slowly, which can lead to problems. And then finally, when doing therapeutic drug monitoring, something we'll talk more about later on in the class, multiple drug samplings and pulling lots of samples for other labs and things like that can be detrimental for very young patients. You can actually lead to some anemias if you're having too frequent a blood draw. So sometimes you have to be really strategic about saying when you're going to get levels and timing them out at the same time with other labs being done concurrently. Here's an example of a kind of a pump setup that you might have for a pediatric patient. Again, for adults, a lot of times you can just hang things and let things run by gravity. But because for pediatrics you want to be very specific about how much volume you're giving and how quickly, you oftentimes will see pumps being utilized to help do that more appropriately. So say for instance, if you have a liter bag of saline, you don't want to necessarily infuse that entire thing into, say, a neonate. Because it could lead to pulmonary edema and other things. So having that pump available and being able to program it appropriately can be a huge patient safety factor. So this would be a kind of a more common setup you might see with peds more so than with adults. And then looking at oral administration can be pretty difficult for certain patients. You also run the issue of actually measuring out the medication itself. So say for instance, someone says give 1 teaspoon. Well, what's a teaspoon? What does it actually mean to you? Because if I go into my cabinet right now, I'm going to have all kinds of different sizes spoons, and I'm not necessarily sure which one's a teaspoon. So that's why we're getting away from using things in teaspoons or tablespoons and doing it based on mLs. And so it's really important that we're administering things with dosing syringes to make sure the dose is being given appropriately. Look at different dosage forms. Oftentimes you need to have things in a liquid preparation for young children because they either can't swallow tablets because they're too young and they haven't developed that skill yet, or they have an aversion to it, so having liquid medications is important. But then you have to look at things like, okay, well, what's the sugar content of this? Because some kids who may be on, say, a ketogenic diet can't receive any excess sugar. So now you have to find a particular formulation for that. So sometimes you have to end up crushing tablets and putting them into solution after that. So again, lots of different options specifically made for peds. You need to look at the sensory appeal of the dosage form. So look at things like, is it palatable to the kid? Like, what's it actually taste like? I'll never forget working, kind of being new to peds, working in the emergency department. You give out a lot of acetaminophen and a lot of ibuprofen, and the nurses came up, they're like, you got to change this acetaminophen. This stuff is terrible. I was like, what's the matter with it? It's a medication. And they're like, oh, the cherry taste is terrible. And so we actually had to go and find another manufacturer and get grape flavored Tylenol, because that all of a sudden made it much more palatable for the children, and you had a lot less of it being spit back out of the nurses. So they ended up liking you a lot better for that. Drug-food interactions are going to be important here as well, especially things that will bind up other medications. So you have to look for things like calcium interactions and things like that. And then also looking at inactive ingredients, especially kids who have a lot of food intolerances or allergies. This can be important. And so being aware of inactive ingredients and what may be triggering certain reactions are important here as well. So as far as when we're dispensing medications for an outpatient use for these kids, make sure that we're obtaining a current weight. It's always very easy just to say, well, hey mom, how much does your child weigh? That information might be old or might be incorrect, so it's important to always obtain a current weight to make sure we're dosing appropriately. Make sure you're checking the dose with available references to make sure that the dose hasn't changed now that they're a different age or whatever happens to be. And we're always making sure we're giving out oral syringes with the liquid dosage forms. That way they can measure out specific doses rather than having to go by a teaspoon. And then the other thing really to do is to make sure we're educating and counseling the patients appropriately and making sure that we are kind of talking down to their level that's appropriate. So obviously talking to a 3-year-old is going to be a whole lot different than talking to a 15-year-old. And so being able to, as appropriate, make sure we're not just educating the parents, but also try to give the kids an active role in their medication management as well. So going back to the final question, which of the following statements would be correct about drug administration and dispensing? Again, we should obtain a current weight. That obviously is definitely true. Children may receive an increased milligram per kilogram dose than adults, but smaller volume administered. Absolutely, that is true as well. Again, we like to have things at a smaller volume whenever possible, makes it more palatable to the kid, or can, if you're being given by the IV route, lead to less risk of having things like you're diluting out the patient. And then adherence to oral meds includes consideration for active ingredients. Yes, that would be true as well. So the answer would be A, B, and C there. Okay, well, that's going to wrap it up for this section. If you have any questions, again, please send them to me, and I'll try to address them in the next lecture. Other than that, I will see you guys next time. Thanks.